It is a great honor to be in Vicenza again. It's a beautiful town. I'm glad that Claudio invited me. It is an honor to be here. And the beauty of it is that it's always a spring when we come here. The weather is good and the area is beautiful. So I'm intensivist and I'm a nephrologist, and I've grown interest in clinical informatics over the course of last few years. And so kind of part of my research is dedicated to clinical informatics. I have no conflict of interest outside of the fact that I've worked with several companies without any financial relationship. It's a more collaborative work. I'm hoping that I can pass some information about history of electronic health records, impact on the outcomes, and making acute kidney injury clinical decision support systems, and hopefully some information about future steps that partly we are moving forward towards. First of all, it is important to remind everybody that computers are not here to replace us. As physicians, we still are physicians. We are the final decision maker in ICU. What clinical informatics is adding is that along with scientific approach and methodology, computers and their computational power can improve our performance. I'm trying to show you some evidence that this may be the truth. So this should not be in any way threatening to the providers on the ground. So computers in ICU started being implemented long time ago. In 1953, we had the first cerebral artery pressure monitor. As you can see, these machines were huge and really space occupying, and the information from them were very limited. And the first ICU monitor was implemented in Japan the year that I was born. And then following that, the progress has been made from first generation, where only gathered data, to second generation when they were able to represent data in a more understandable way, to the third generation that we are dealing currently with up to now. This is the first ICU bedside monitors. As you can see, occupies half of the room, and it is not enough because all the data needs to be interpreted in a different room by a human being. So like before, that telemetry machines had to have a person looking at all the telemetries. These devices also needed somebody to be able to interpret all that data. The reason was that the data, as you can see, is absolutely not interpretable. They are not useful unless you can make a trend of it and try to kind of make sense of that particular data. So electronic health record moved from what we used to do. This is a real patient chart from about a few years ago, about 20 years ago, to something that we adopted from our colleagues in accounting services, and that kind of puts numbers in the tables and we try to make sense of it, to something is more ambient and physicians can use, is based on the organs and tries to kind of present data that actually we need for decision-making processes. Indeed, we went to our ICUs a few years ago. We gave any clinician saw a patient in ICU, said that, what information did you use to make your decision? So outside of all the information, there were few information that we never used to make our initial decision. For example, bilirubin was the lowest used information. Hemoglobin, blood pressure, and heart rate was the most used information. So why do we need to put bilirubin at the first day to clutter our medical records? So there's a science behind how we can make it more ambient. The use of electronic health records went increasing because in United States, Center for Medicare Medicaid Services have implemented some incentive programs that has three phases. The first phase is to data capture. A second phase is to advance clinical processes using that electronic health record and hopefully improve outcomes. As a result of that, as of 2008, when the number of institutions using electronic health record was less than 10%, it has increased to about 95% plus. However, majority of institutions in US are using very basic form of electronic health record, which is only gatherer of information rather than helping clinicians to come up with appropriate decision. Implementation of electronic health record could be beneficial, as is shown in many studies. This is one of them in ICU that decreases pressure, ulcer, ventilation, and medication errors. Or it could be dangerous. This is a pediatric patient population, and after implementation of computer interorderly set, as you can see, mortality significantly increased, and this was thought to be due to delays in delivery of medications and so forth. So it could be dangerous. In the setting of acute kidney injury, most of our studies are focused on alerting about patients who have acute kidney. The reason is that when you look into ICD-9 codes, administrative data that identifies acute kidney injury, sensitivity of those are only 20%. 80% of patients who have acute kidney injury, they do not have any documentation. So we really do not know how many of patients with acute kidney injury we actually have diagnosis of acute kidney injury for them. So using electronic health record, we try to identify these patients very early. Hopefully we can improve their outcome. There are many of them. And the last one is what we did in our institution. I'll show you the result of that later. These are studies that showed the improvement in outcome. This table comes from ADKI 15 that was held in Banff, Canada. I added 2 studies at the end because these came after that ADKI. PARC study is a before and after design study that looked into implementation of e-alert that alerted nephrologists automatically. So when patients reach definition of acute kidney injury, didn't go through intern or mid-level provider, directly implemented an alert or consultation to a nephrologist. And they were able to show by that simple intervention, severity of AKI decreased, missed acute kidney injury number decreased significantly, and renal recovery increased. And the second study came from University of Pittsburgh, Dr. Kellum group, that they looked into 500,000 alert patients that were included at the time that alert was working. So among 60,000 of patients who, among these 500,000 patients, developed acute kidney injury, if they received alert, which was a sign in electronic health record that if you clicked on it, recommended nephrology or critical care consultation, they were able to show decreased mortality, decrease the need for dialysis, and length of stay in ICU. Very simple intervention. And these are studies that didn't show any benefit, and one of them is actually randomized clinical trial. I'll show you some data regarding to that study as well. So the idea is that when we alert physicians, we improve providers' chance to change their behavior. Therefore, we can improve processes of care and therefore patient outcome. But this process is not as simple. There are many steps that can potentially impact the results of that process. So technological factors, if they are available in the hospital, they are accurate or not. If you receive inaccurate alerts, after a week or 2, people start paying attention to it. If they are clinically relevant, if you receive patients that are high risk but you can do something, they are not high risk because they have diabetes or history of CKD, they are achieving acute kidney injury because they are receiving nephrotoxins, then this would decrease fatigue and also clinically very relevant. If they are basic or advanced, human factors are important. We have this thing, we call it habituation. If you put a light in the corner of ICU for 2 weeks, everybody asks what it is and they pay attention to it. After 2 weeks, nobody even notices that the light is there. And this is based on experience that we had on Mayo Clinic. Who is target? Is it physician? Is it interns? Is it providers or administrators? And what is the context? Are you using this for administrative purposes or for clinical purposes? How it is delivered? If you are mandating something to be done for a patient or just putting that information somewhere so somebody take a look at it, this is important in an outcome of the study that you do. Acknowledgement requirements. So if you ask physicians that they have to let you know that they notice that the patient has acute kidney injury or not. Where do you place it? Is it in the medical record or a different app they need to open to be able to notice it? Is it in eyesight or is it in your back? So you need to turn your head to be able to see it. These are all important factors that can affect the results of this. So this is a study was done in Belgium, Dr. Host group, Colpert, They looked into pre and post implementation of AKI alert. As you can see, in an alert group, which is 600 patients, they received 1,400 alerts. These alerts went to intensivists. I'm sure that intensivists in Belgium, they're very patient because they received 1,500 alerts in a course of 3 months on acute kidney injury patients. But as a result of that, they were able to show processes of care improve, and return of creatinine within 8 hours was significantly better on alert group in comparison with post and pre-alert time. This is the randomized clinical trial mentioned, was published by Wilson et al. They screened about 24,000 patients and enrolled about 2,400 patients in 2 groups. Half of the group received alert, half of the group they continued with the standard of care, and this study did not show any benefit. The alert was one-time alert based on serum creatinine alone, included patients in ICU and the floor at the same time, and also alerts went to interns and mid-level provider rather than intensivists in Belgian study. So research consideration for the future, I try to format it based on PICO format. So for patients, you really need to kind of look into higher risk patients to begin with. So if you go in an outpatient clinic, use alert, you are going to receive a lot of alerts that are not real, and they are based on chronic kidney disease. So if you go to ICU, however, among high-risk patients where incidence of acute kidney injury is high, you can achieve better results. Intervention, if it is low or high impact, the UPMC study that enrolled 500,000 patients, the impact of intervention was small, so they had to include 500,000 patients to see differences. However, in the Park study that they asked nephrologists to intervene, which is huge intervention, they were able to show benefit with enrollment of 3,000 patients. Comparator, if you do use randomized clinical trial in one institution, you can potentially have some Hawthorne effect, means that those who don't receive alert, as they know that alert is going on in the background and somebody is watching, they may actually do better. So you may not see differences as easy. So most of the studies have shown benefit. They are before and after, when clinicians were not aware of such impact. Or you can use randomized clinical trial in a stealth-wedge cluster randomized trial format to be able to avoid such effect. Outcomes, are they realistic or unrealistic? So you can potentially say mortality, which would be very difficult to find mortality difference by one intervention, or you can focus on processes of care, need for dialysis, or those that are more achievable, more relevant to acute kidney injury alerts. This is a very nice study done in UK. In this study, it's pre and post intervention. As you can see, they were able to identify acute kidney injury patients, and then they came up with this paper form of protocol or bundle, as they call it, and then they made it available clear as a paper form and then computer form, and they put a stop when clinicians could not pass unless they were able to address the concerns. So this is the blue protocol that they came up with for management of acute kidney injury, and then they moved to the electronic form, and they were able to, at the end, the last part of the project, they were able to put stop. So clinicians had to address acute kidney injury before they moved forward. They couldn't proceed with their daily work unless they addressed it. Interestingly, compliance with the bundle before this stop was about 2% within the first 24 hours. After implementation, increased by 10 times, went to 20%. Still after that stop sign, there was 80% of patients were not compliant with that. They showed that if you are compliant with the care bundle, within the first 24 hours, mortality in discharge, 30 days and 60 days improved. They did a follow-up study, and compliance with the bundle was a significant factor in mortality. So now we are moving a little more towards the future, how we can address these things. Patients come into ICU with a baggage of different information. They come with comorbid conditions and diseases that they carried their whole life. And they are exposed to different things, nephrotoxins, sepsis, surgical procedures, and so forth. They also generate significant amount of data, vital signs, laboratory data, EKG data. They are all information that we can gather. And also they come in with a lot of socioeconomic or cultural values that we do not usually consider to identify patients that are high risk. So to be able to successfully provide clinical decision support, we need to gather all of this information, try to make prediction model based on all that information. I called it ERG because we didn't have EKG for the kidney. I called it the exposure renogram to be able to be close to EKG. And then the descriptive part would be something that identifies patients that have acute kidney injury. Prescription is when you link all that information or risk factors or modifiable risk factors with the current best practice knowledge and try to improve patient outcome. So I'll try to take you through these steps one by one. So acute kidney injuries, clinical decision support, do a lot of things. Alerts are only one of them, and most of the studies so far have been focused on alerting patients. There are very few studies that looked into other aspects of what the electronic health record can provide. They can remind us of tasks that we have to do. They can critique us, say, why are you using NSAIDs on this patient, interpret the data for us, and predict something in the future, diagnose for us, assist our management, or suggest different intervention. Now, this is exposure renogram. Equivalent to EKG. Again, patients come in with different information, and we can use all of the information to be able to reach a prediction. We focus on this part in development of this particular model that I'm going to show you. This is a result of ATKI 16, was held in Hyderabad, India, and we felt that most of our focus are inherent factors, age, CKD, diabetes, background that patients have. However, exposures and patient care or process of care are also important risks of acute kidney injury. Socioeconomic access to health insurance or health centers or environmental factors are also important. So whenever we use any prediction model, has to consider all that factor with clinical risk scores can potentially provide better information. Now, we use the hemodynamic data. Most of this data outside of age are data that patients generated, their laboratory data, their vitals, and also their urine output. We use the technique called random forest, statistical technique, and this model predicts acute kidney injury, gives you a score from 0 to 100. Performance of this model was found to be really in validation cohort 0.88, which is really favorable. And this is output of that model in one patient. So patient came in with very high score continued to rise, and this red line is the time that he developed acute kidney injury. And over the course of time, risk was modified based on volume removal and antibiotics, and therefore patient slowly recovered in the future. Now, acute kidney injury sniffer is the part that we identify acute kidney injury. Most of our studies have been focused on. I'll show you what we need to, as a baseline, to generate that. We need a lot of data sets to be able to identify baseline serum creatinine, current serum creatinine, urine output. These need to go to a repository, and then you generate an algorithm and generate some alerts. In our study, we were able to develop such model that is able to identify patients with acute kidney injury, 96% specificity, 88% sensitivity. Difference between ICD-9 and this device was the sensitivity that only 20% of patients were identified by ICD-9. 80% of patients who left ICU and had acute kidney injury had zero documentation of acute kidney injury. So this is how it looks like, the beta version. These are patients with the number assigned to them 0 to 3, and 3 is based on a stage of acute kidney injury. If I click on 3, it gives me the timeline of progression of acute kidney injury. The reason is creatinine or urine output, and some baseline information as well. Now, the last part that is important, and I'm hoping that I can pass the message as a future direction, is what we can do with that information. So if we have knowledge-based best practices, if we have patient-specific information and mode of communication between these two, we can provide clinical decision support system. This is what we are suggesting as future prescriptive model that hopefully comes to fruition. Now, future steps should be like that. This is what we do as nephrologists at the moment. We are very reactive. We wait for clinicians to call us in ICU or hospital, call us for dialysis. Most of these patients have progressed already to a stage 1 and 2 and 3, and when they call us, most of them need dialysis, and there's too late for nephrologists to be able to do anything. So late practice, when you catch these patients late, most of the time we only have a chance to pray, because these patients are kind of outside of the window. We can intervene appropriately. So I try in the next few slides to compare electronic health record that we consider as a near future availability to a GPS machine. So GPS has the map of roads, and electronic health record should have information of the patient. GPS is able to provide the road, the path to the destination, and EHR should have the same factor. Information about current state, so if there is a construction down the road, the GPS can find it. If there is a surgery tomorrow, this electronic health record should know it. GPS cannot potentially give you what happens down the road, but electronic health record may have it. GPS cannot automatically drive your car. Hopefully in the future it does, but now it cannot drive your car, but electronic health record can actually do it for you. It can order UA for a patient that is high risk. GPS can force operator to not to go to a road that is dangerous, but we can force physicians to avoid dangerous issues. GPS, if it is late, you want to pull your hair out, and if electronic health record is not real time, it is difficult as well. We have to be able to zoom in and zoom out in electronic health record and GPS, see the whole roadmap and street by street. If you make a mistake, it tells you turn around. If somebody gives this patient NSAID, should not be punished, should let that physician know that what we can do to mitigate that risk. It should be able to allow clinicians to make a different decision. It should be incorporated in workload, otherwise it never works for us. It should have high resolution, it should be widely available, and it should provide report to us. This is what we get after sepsis management for each patient. I receive such email if I pass or failed, and this is information is gathered. It's a kind of feedback that we provide to consultants and fellows and residents. So right information, right person, right format, right channel, right time, and this would provide us a chance to be proactive, so we get engaged with patient care very early and avoid further damage. Take-home points: EHR utilization is on the rise, electronic surveillance beneficial in most studies, design is very important, and hopefully future CDS can help with improvement in outcome. With that, I thank you for your attention.